welcome. I am Christy Johnston, and I'm going to be kicking off our events today. Dr. Gerard will be over shortly, but he was called into an emergency meeting, so bear with me. I'm going to do his introduction for our speaker. We really thank you for joining us today for this academic day. It's sponsored by the Office of Academic Affairs, Graduate Studies, and the Center for Interprofessional Education and Simulation. The purpose is to unite faculty, trainees, and staff from the schools of health professions, nursing, medicine on all three campuses, as well as KU School of Pharmacy, Department of Pharmacy Practice, for a day of learning and networking. This year, academic activities with the Interprofessional Preceptor Summit that is a full-day activity. The goal of today's summit is to provide interactive professional development opportunities around the topics of interprofessional education and collaborative practice in the real world. Each year going forward, themes will be selected which address important topics, issues, or activities involving faculty, trainees, and other professional schools. If you would like to suggest themes on or serve in next year's committee, please contact Dr. Bob Klein or myself and Marty McLaughlin Jarvis. Today's activities were planned by a committee of faculty who work directly in interprofessional healthcare training activities on campus and chaired by myself, Christy Johnston, and Marty McLaughlin Jarvis. I hope you have been able to take part in some of the morning's summit activities. And these presentations and posters that are outside are networking opportunities, but we have both students and faculty that are providing their overview of some of their interprofessional work. And it really is outstanding information that will help us develop the skills necessary for our campus to become a leader in interprofessional education in the future. It is our vision that our faculty and staff will become experts in this area and that we can train healthcare professionals of tomorrow to be active participants and leaders in team care environments. We've invited our keynote, Dr. David Moem, here today to share how patient care will look in a new era of the constantly evolving healthcare systems. Dr. Moen is a principal of consultant for Moen MD Consulting and board chair of Team MD. He has spent his career providing thought leadership to teams working to achieve the triple aim, results for high-risk patients in hospitals, clinics, and community settings. He worked at Fairview Health Center in Minneapolis for 25 years as an emergency physician and physician executive. While there, Dr. Moen's team led development of patient-centered medical home in more than 50 primary care clinics. They also designed and implemented population health infrastructure to support Fairview's employed and partnering independent physicians in new risk-based contracts. In 2011, Fairview Health System was named a pioneer of ACO by Medicare. He now works as a nationally recognized consultant to healthcare systems, adapting to the changing healthcare market trends. And now I would like to introduce Dr. David Moen. And Dr. Moen, I'm going to just do the one slide that some are interested in for CE. And for CE, you will text a message here to this phone number with the code 2908. If for some reason you are not able to get that to work, then you'll just let our staff outside know and make sure that your information is on the sign-up sheet so that we can make sure that you get your contact information. Dr. Moen, would you like to step up to the podium?
Thank you, and can you hear me? I want to make sure you can hear with the mic. Is that working out there? Good. Thank you very much for coming and for your commitment to interprofessional education. It's really a key time in healthcare to think differently about how we work together. And I think interprofessional education is really a foundation of much of what we need to accomplish. Because this is CME, I'm going to go a little bit more deeply into my background through a disclosure. So this is the scope of work I do today. I left Fairview Health System in 2012. At that time, I was CEO of the Physician Network. Started working with multiple organizations contemplating the shift to population-based care and have supported health systems in other markets. I haven't worked in Kansas City, But I also have had an interesting opportunity to work with United Health Group's Venture Capital Fund, and it's a fund that is investing in companies that are transforming healthcare. So that's been a very interesting lens. One of the companies that fund has funded is TeamMD, and I'm chairman of that company, and we'll touch a little bit on TeamMD, so you should be aware that I'm chairman of one of the companies that'll come up. The remainder of my activities I don't think will impact what I'm talking about today, but they're all there as you would want. We're going to get through 2 sessions, I believe. We may only get through 1. The first one, we're going to talk about a trend which is emerging across the country, which is community-based primary care teams in much more holistic care models that leverage the strength of pharmacists, social workers, nursing staff, RTs, OTs, the spectrum of providers that touch patients to the care of patients that are higher risk and demand interdisciplinary or interprofessional care in order to be successful. And then we'll touch on some chronic disease management as well. So being an emergency physician for 20 years, you have a great lens on what doesn't work in healthcare. Most of what comes into an emergency department is not an emergency. It's usually some sort of system failure. And being personally acquainted with that for 20 years really fueled my interest in the populations we weren't addressing. And Rose is a great example. This isn't Rose, and Rose isn't her name. She was 83 when I met her in our emergency department on a Saturday evening in Minneapolis. She lived alone in an independent living and had fallen earlier in the day, couldn't get up or get to the phone. For a couple hours, she laid on the floor with right hip pain. She eventually worked her way to the phone and dialed 911, and it was probably 9 in the evening on Saturday by the time she got to the emergency department. Rose has mild dementia, the type that when you don't know Rose, you have a conversation with and you think she's a sweet older woman, but you go back in a few minutes later and you might have a similar conversation. As she was in our care in the emergency department, it's now getting to be 9:30 at night, and she'd fallen now over 6 hours ago. She was becoming a little bit more agitated. Unfortunately, in the mind of an ER doctor, she did not have a broken hip, because if she had a broken hip, I had a diagnosis, my work's done, up she goes. That's such a strange way to think about it. However, truly, when you're faced with an elder, now it's 10 o'clock at night on a Saturday night, Medicare does not pay for a ride home, she doesn't have a broken hip, what are we going to do with Rose? Now, fortunately, Rose had some bacteria in her urine, as most women her age do. However, it could have been a urinary tract infection. It's very possible a urinary tract infection could have been a precipitator of the fall. Entirely rational for me to say at that stage, now 10:30 at night, let's hospitalize Rose, treat her for the urinary tract infection, see what goes on with her mental state, and try to figure out, can she live alone? All those complex questions that need to be answered in order for us to believe Rose is safe. So Rose was admitted. As is the case in over 65% of these type of patients, she developed delirium in the hospital. Hospitalization is a very traumatic experience for the elderly. And over 60% experience delirium. Delirium is a temporary state, however, it leads to long-term permanent cognitive impairment. So every episode of delirium contributes to mental decline. So Rose struck out at the nurse at 3 in the morning, was confused, fell out of bed, and hit her head, and her level of consciousness decreased. She went down for a CAT scan that showed a subdural hematoma. She aspirated. She was in the hospital for 10 days, couldn't find a place for Rose to go. She extended her DRG length of stay. Finally found a place for Rose to go. She was in much worse shape than when she came in. She went to a nursing home and died 180 days later. We did a root cause analysis at the hospital. The quality committee met. Person fell, got a subdural. Clearly was the nurse's fault for not paying enough attention to Rose. And the root cause was that we needed to have thought about restraining her, different medications, all the things that we think about in that setting. The night nurse worked in that unit for another 30 days and then quit her job. Rose's story is happening around the world, especially in industrialized countries, every day. Rose represents a growing population of frail elders that really respond well to a different approach, which is actually not waiting for the tragedy to happen, but finding these people and supplying a different set of services prior to the fall. About 16% of the Medicare population spends about 70% of all the resources, and as people become more socially isolated, they tend to utilize the healthcare system as an infrastructure to basically survive. And it's a very expensive solution to this problem. The people who fall into this category, some of them are frail, many of them are not frail, but they have multiple complex conditions and they don't have social infrastructure. And so they are extremely high risk. And other people that fall into this category are people with disabilities. So there can be younger people who have a series of complex conditions that lead to this situation. So we looked at this data, this 16%, and began to examine who are these people, what do they look like in the community, and is there a possibility of designing something different? And we came up with a model that actually moves from what occurs on the left with usual care to what you see on your right, which is a team-based approach that includes a primary physician, social worker, RN, nurse practitioners. There's a team of 10, basically, with one physician and 9 support personnel that work with a panel of about 600 patients. This is not a new concept. Actually, there have been multiple studies that show that more proactive holistic interventions in the community for at-risk populations work really, really well. But the basic concept is to defragment care delivery, take it out of silos, and proactively apply it in the community to those that are at risk. The studies that have been done in this area have been fairly large. This is a VA study and has over 11,000 patients that were followed in this study, and it showed a very dramatic decrease in the total cost of healthcare for this population, with the major money coming out of hospitals and nursing homes, interestingly enough, and most of the investment going into home-based resources. You also saw a shift in the number of bed days, obviously, and an increase in patient visits and importantly, home visits. So this isn't new science we're talking about. This study actually came out, I think, in the early 2000s. The other really what I would call rigorous study is a randomized controlled trial that has been done in Philadelphia, and this was actually reported to Congress in 2011. This study's been going on, I think it's now in its 14th year. Over 3,000 adults have been randomized into a team-based, community-based approach versus care as usual. And this is a program that has nurses and social workers and then a physician partner that work in the community directly in the homes with patients. And what's powerful about this is it follows our randomized control trial methodology. And this is what that study has shown. And this was reported to Congress March 2011 by Dr. Ken Colburn, who's the internist in Philadelphia that runs this company. And one of the reasons for this being reported to Congress was because Medicare was contemplating shutting this down because the payment models weren't quite working for it. And Ken was advocating and managed to get Medicare to continue. In fact, what Medicare determined, the question they had for Ken was, when can you discharge Rose from your program? And they looked at the data, and the answer was never. This is a from beginning to death program. And for some people, it lasts 10 years. This is not an end-of-life problem we're dealing with. It's a chronic disease, lack of social infrastructure problem. So to pigeonhole it into, well, this is a palliative care solution is important, and it's about 30% of the cost. Actually, the majority of the cost resides not toward the end of life or with end-stage chronic disease. It's often multiple diseases and lack of social infrastructure. Interestingly, these are the visit types. You probably can't see some of this, but home visit is the top one and telephone call is second, followed by a group visit. These patients came in once a month in group sessions and had conversations about their conditions with a nurse. And that ended up being very important peer support. Often people go to the doctor because they're lonely, and often going to your peers ends up being a better experience. Physician office visit was 1% of the visits. Sometimes we get physician-centric in the way we think about care for patients. And you can see that the vast majority of what's occurring here is not a physician office visit. So what we've learned in really studying this population, this kind of work, is these are what I would call the operational requirements. High-touch, team-based, relationship-oriented care is at the foundation of every single one of these successful models. Focus on building trust with the patient. It's often not through the lens of the doctor's trust in the office. It's often through the lens of someone that they trust in their home. That's usually not the doctor. That was a big, tragic learning for me. I thought I was like super important. Interestingly, proactive engagement means not waiting for the crisis, but actually looking for what are the factors that lead to this, and then engaging the models in the community settings. These models can be launched in the home, senior housing campuses, nursing homes. Senior housing campuses are easy because there's an aggregation of these kinds of patients. However, they reside everywhere, even next door to you perhaps. Very important that there's 24/7 team responsiveness. Health plans in markets where they're at risk, Medicare Advantage markets, do what's called case management, which is a version of this that actually doesn't work that well. And part of the reason it doesn't is it's not integrated with the system in a way that makes sense. So the nurse from the health plan might say, you should start this medicine, and the doctor says, well, she's allergic to that. We tried her on it, blood pressure bottomed out, or whatever the case may be. So health plans aren't integrated with actually where the patient gets their care. The other thing, patients don't trust health plans. I worked in a call center not as someone calling, but as observing, 1 out of 18 patients returned a call to the health plan about their health. At Fairview, over 9 out of 10 patients called by the clinic call back. Our level of trust in the system is much higher. These health plan-based activities suffer from lack of trust and lack of integration. There's some new technologies that have enabled teams to communicate. They're not called electronic health records. That's a key part of our infrastructure. However, social technologies that allow families to connect, that allow home care to connect with the doctor. The phone is an amazing technology if you answer it. You just have to answer it. One of my favorite lines is just answer the damn phone. We have built so much infrastructure around not answering the phone. It's just amazing. And then the other key thing is changing contracting. Very challenging to do this work in fee-for-service models, and you're saving so much money for the system. There's obviously better ways to contract. One of the reasons why, when I looked at Team MD, I actually approached United as a partner because they're the people that need to change the most. And sometimes if you start with the person who needs to change the most, that's a good way to, at least if you're started with them, you know the people who have to change most help design it. There's a good chance they're going to change. And interestingly, they are doing some really great stuff with payment that will translate to other markets. So I wanted to shift for a moment and have you at your tables talk for a little bit, a couple minutes, about how do we best prepare students and trainees for an environment that demands this level of interprofessional work. And one of the things that we see in these models is nurses' accountability for what's going on goes up. Pharmacist accountability goes up, respiratory therapy accountability, and I'm talking about accountability to the patient, but accountability to each other. And these models don't allow everybody to be quiet and then blame the doctor when something goes wrong, or just wait for the doctor to tell everybody what to do. They demand us all to be professionals and to be comfortable expressing our point of view and specialty, our special knowledge that we all carry from our education. So at your tables, I would love to see you talk about what are the things we really need to address if we're going to get this done. You can talk about cultural things or just really tactical things. And then maybe you want to give an example of something that's going on in this institution that you think highlights the change that needs to happen. So thank you. Go ahead. 2 minutes. All right. I love that you're having the conversation. I want to continue to move. I wondered if somebody could stand up and just report out on their table what was the dominant theme that got the conversation at your table. Anybody willing to throw their... I heard one over here that I happen to be close enough to hear about afraid to speak up. You're so funny. That's awesome.
No, I was making a point that in terms of how do we best prepare students for trainees. I'm a pharmacist, so coming from a pharmacy school and years of training students in pharmacy, we have had to develop in our patients over the years and decades a better competence and clinical competence to have the confidence to take part and to ask questions and to make suggestions. And so we're bringing that up as an issue, and then I guess personalities and backgrounds of certain students not having that mentality of having the mentality instead of just waiting until somebody asks you
Yes,
for your opinion rather than being willing to speak up.
I love that.
We kind of focused a lot of our conversation on that.
Very common theme when you start working in teams is that fear of putting yourself out there. What if I'm wrong? It's not like taking a test where you can go, oh, I missed that question. It's like taking a test like my colleagues are going to hear how dumb I am if this is wrong. I mean, that's a real fear. All of us have. So I love that you brought that out. That's a cultural issue, and we really have to address that dynamic if we're going to be effective at harvesting the input of every team member. And as a physician, I can tell you I had a lot to learn about how to be such that you would speak up. And it wasn't like I was trained to be. So I had some undoing to do, and I won't get into all the therapy. You can talk to my wife about that. All right, any other theme? Yeah. Yeah, so what I'm hearing there is, one, a holistic view of the patient and a recognition that it's holistic input that likely is gonna, and holistic skills that are likely gonna bring to bear a solution that actually addresses the whole person, which is the person-centered care to me is not their disease, it's them, who they are, which often has more to do about not the disease parts. It's 80% of what drives cost is the non-disease parts. So awesome, I love that, thank you. Any other, yeah?
One thing that we talked about was that graph you showed is those home visits was like the big majority of things, and something that we need to start moving towards is getting that culture change of care not happening in the clinic, not happening in the hospital, but happening where the patient lives. And it's patient care, you go where the patient is. Most of the time the patient's at home, but most of us, we are not used to that. And something like, can we start getting our students there? We have some students in our group who they're doing the IPPC clinic, and they are doing some home visits and those things. So I think we need to start doing that culture change with our education and exposure, and for us too, because that's something difficult. Like, I haven't really done a lot of home visits and those things, so I don't know if I would be able, like, how do I precept that?
Yeah, lovely, awesome. And the business model is very challenging because of windshield time. And so, and who to go home and see. If it's the person who lives in Arizona in the winter and plays golf in Kansas City in summer, we're gonna go out and do home visits. I'll just be here to report. They can come to the clinic. If they can go to Arizona and golf, you know what? You gotta come to the clinic. Now, they can go into a concierge model and pay $1,000 a month to have somebody come to their house, but we really can't sustain a home practice for people who have the capacity to go to a centralized location. So that said, there's a whole population that the transportation to and from is such a barrier that leads to cost that actually it pays to spend the time. And there are ways to build models that distribute that with hubs and spokes. So a hub might be on a senior campus, a spoke is the homes around it. So different ways of thinking about distribution and the types of people that are distributed. It's often not the doctor in the home, it may be a community worker, but they have the access to the doctor over the phone if they have a question type of things.
So we just talked about this when you mentioned concierge medicine. I just had a friend pass away 2 weeks ago, and she spent the last 2 weeks in her home.
Nice.
And it was a very, very unique model, and she actually utilized concierge medicine.
Yes.
And what I realized in this conversation, it was more than just having that team approach. She actually had the connection with the nurse who she's known for many, many years. Same nurse was coordinating her home care in her home. And so she coordinated the home, the social worker, everyone there. So it was a familiar people, person.
Totally.
And my friend was completely independent here. She has no family here, no really close friends. And so it was, she was able to stay in her home because of that model.
Wonderful.
You mentioned earlier the social connection, and she doesn't trust anybody. And it was the fact that that was a nurse that she's had for that many years was saying, this is what we're going to do, and this introducing these people coming into the home. It was really phenomenal.
Lovely example, and in a model in the Twin Cities now that's operating on senior campuses and whatnot, 97% of patients are actually dying in their home. Their home might be an assisted living or a memory care, but you go to other markets like New York City, there's still a massive number of people dying in ICUs. Intensive care units are full of these people.
We also need to think about harnessing the technology in the home. And
Love it.
iPads, FaceTime, Zoom.
Yep.
If you really want all these different services to have true input, one way to get in there is just use telemedicine and connect all
I love it.
nurse or family members.
That is so true, and one of the barriers there has always been payment, right? Well, we don't get paid to do that. It's a true barrier. That said, again, some of this is being broken down because of the demands. The market is demanding that we address this. CMS is on this. So Kansas City, I've been informed, and it was gratefully helpful, is immature as a healthcare marketplace compared to like Seattle, Minneapolis, where there's tons of aggregation and multiple at-risk contracts and capitated groups. Las Vegas is an entirely capitated, that means paid per person market. Orthopedic surgeons are not paid for surgery. They're paid per person for orthopedic services based on the number of patients in the panel of the clinic. So I'm just here to report that Kansas City may be at a certain place. However, what's happening at CMS is meant to transform all markets. You see a lot of Medicare patients. This is changing. And so this type of thinking in our academic institutions, training our future providers, and in our health system, academic health systems need to begin. So some of what we're talking about is what I would call soft culture work. How do you develop soft skills in people, especially doctors? I mean, we were kind of recruited besides our soft skills sometimes, and some people have them, but it's very challenging with certain kind of people to develop soft skills. So I'm going to talk a little bit about a project that we did that actually moved the dial in some important ways. So when I was medical director of a large emergency services division, we were seeing 72,000 patients a year. That's big. And we had won 3 national patient safety awards. And that was based on Medicare outcomes that were measured for acute heart attacks, for congestive heart failure, for pneumonia across 42 states. And we were always in the top 5 for mortality and complications and length of stay. And so I would view us as very high performing. That's what I like to tell myself. And then we did a safety climate survey. And we found out that 35% of our staff would not be seen in our department as a patient. Now, the good news is that's good compared to everybody else. We were in the 70th percentile, I believe. So you could say, well, you know, we're in the top quarter. You could go, oh my God, 1 out of 3 of us wouldn't come here as a patient. So we put together an interdisciplinary team of 12, 2 docs, 2 nurses, 2 technicians, our staff that came into the department like RTs, anesthesia, got around the table, and we said, the theme of the meeting was, let's make this a better place to work. And I said, I really would love to figure out how to make this the best place to work. And how do you guys feel about the working here? And everybody started their stories about, this is the best place I've ever worked. We've won all these awards. I love this place. It's fantastic. And then the nursing director and I had this little secret plan. It's called the slide with that data. And after a half hour of everybody patting ourselves on the back about how wonderful we are, we put the slide with the data that said 35% of us wouldn't come here as a patient. And I had finally learned I didn't have to have the answer to fix that. That was such a relief to me when I finally learned I didn't have to have the answer. I actually could go, help. I have no idea what to do. This team came up with a process, and it started with a technician. There was 2 minutes of dead, painful silence when that data went up. Painful. Finally, a wise 60-ish woman who was an EKG technician in our department had the courage to say, with her voice shaking, I think I might have an idea about why it might not feel safe here. I said, I'd love to hear it. What do you think? I had a very rough childhood. My dad was an imposing figure in my life. He didn't beat me up, wasn't sexually abused, but he was just really tough to grow up with. And I'm sorry to say this, Dr. Moen, but most of the doctors here are male. You guys are all kind of big. And frankly, when I come into the department, I can't let go of my childhood. And what that said to the group is, okay, now we're telling the truth. We told the stories we wanted to hear for the first 30 minutes. Now we're moving into a zone of truth-telling. Her courage unlocked the rest of the conversation, which revolved around hierarchy. I'm afraid to speak up because even though you appear to be a nice guy, you scare the crap out of me. And, you know, we started to write these things down. Someone else said, at the change of shift, we spend the first half hour complaining about what the previous shift did and how terrible it was, and we just rip on them. So we called that backstabbing. I don't know if this probably doesn't happen in Kansas. And then another story came up about patients sometimes see us talking about, wow, it was so fun Saturday night, and they have a dying family member 5 feet away. And as a staff person, I'm standing there going, do I want to tell them that they should be quiet and be perceived as Mother Teresa, which will certainly get me browbeaten out of the group? What do I say? How do I say, I think this looks unprofessional. I think that somebody's hearing you that's offended without being perceived as Mother Teresa. So we wrote down these stories, and we just kept writing, and we came up with 3 themes that needed to be addressed. If we were going to make this a better place to work, we needed to address hierarchy. We decided we could only do 3. We needed to address the perception that patients have that's uncomfortable for us to witness, that are a poor reflection on us as a team, and we need to address that. And then we need to deal with backstabbing. So we came up with 3 phrases we called safe phrases. I need clarity. If you see something that's happening and you're a technician and the doctor's putting the chest tube on the wrong side, you can say, instead of, I think you might be putting the chest tube on the wrong side, or whatever I might have to say, just say, I need clarity, and everybody in the room would know. Pause. The second phrase was do the hustle. That's for if you're witnessing something that's being said, you kind of want to give your teammate a clue that, I think you're talking about a party and someone 10 feet away is dying. If you said do the hustle, everybody would go, okay, and the family would think, oh, they're doing the hustle. Well, that's a little more acceptable than, come on, guys, straighten up. So do the hustle was the other one, and then cease fire was for if you came into the nursing unit or the doctor's lounge and somebody's ripping on somebody, you could just say ceasefire. And we said, okay, now how do we make these culturally acceptable, safe phrases? So each team member went out and socialized this with 4 of their best friends in the department and came back and said, that resonated. Everybody went, yeah, that's what's wrong. That's what we do, and wouldn't it be cool if we could make that go away? And then those 4 talked to, one of those 4 volunteered to talk to 4. Eventually we got to all 100 and some people. And then we set out to say, we're adopting safe phrases. We want to make this the best place to work. We've decided it's our work to make this a place where we feel safe. And we believe when we feel safe, our patients will feel safe. So we went on a 2-year journey. We had things called the stories of the Cultural Revolution. So when someone used a phrase, they could write a story about the phrase and the impact it had on their perception of this place as a place to work and on patient care. One of those stories was a nurse who went into a room and a patient's O2 sat was 79% and the alarm wasn't going off. Went out to the nurses' station at one of the top 5 emergency departments in the country, and the alarms had been shut off because they were going off so often from coming off fingers, and that they decided it was making noise. So someone had disabled the alarms for the back part of the emergency department. No one knew that someone did that. That would make me feel kind of unsafe if I were working there and saw that, oh, we disabled the alarms. Oh, okay, well, that's because they're making too much noise. So, we started uncovering things under the blankets that go on, even in Kansas, I'm here to report, that we had no idea were going on because we have been flying around accepting National Patient Safety Awards and are pervasive in our environment because of the cultural aspects of the work that aren't done as well as they do to facilitate people speaking up in ways that are productive and safe. So these safe phrases, the stories of the Cultural Revolution. So monthly stories came out of what people had the courage to address. And it was framed as having the courage to use the phrase. And it was celebrated. What happened, we also developed team training, and we infused in the training some of the behavioral things we were trying to reinforce. So we had doctors in simulations intentionally making mistakes in the scenario, not telling anyone they were going to intentionally make mistakes. And we observed how long it took for team members to speak up. And then we would come back and do a debrief and say, when did you recognize the mistake? What held you back from speaking about it? So, and we started reinforcing through multiple behavioral trainings. What happened is in 2 years, 95% of our staff felt safe. being treated in our emergency department. And our patient satisfaction for the first time went over the 90th percentile. And I think for too long I was focused on the wrong problem. Patient-centered care starts with people-centered care. We have a tendency to think, wow, those people with a problem over there. It all starts here with how we view each other, and the cultures we build will translate to the safety of the care we deliver. So I wanted to share that story because it's very tactical. A lot of times as a doctor, when someone say, we're going to talk about culture, I'd be like, sputum culture or the urine culture? That's like such a squishy word in my world. And so this was something I could understand. Like, okay, I get it. And we actually did something tactical that you could do. And we actually did it. And we measured data. And the CFO who's going, Dave, you're spending all this. You have an amazingly profitable emergency department. That was the other thing that was helpful. Because we also had amazing throughput. Our patients only spent 1 hour and 56 minutes on average in our emergency department. Whether you were admitted, discharged, we averaged 156. Just if there's any ER people here, the faster they go through, the more money you make. It's just a simple fact. If you have a fixed structure and more people move through, you are more efficient. And if you can do that and win quality awards, you're really doing something amazing. But the CFO would say, you bought this mannequin, you're doing all this training, you're paying people to, when are we going to stop that? And when the patient satisfaction went up, it's like, okay, you can keep doing that. A lot of people don't get that personal development is largely missed in our education. And that personal development is what facilitates teamwork because we become aware of each other. As we become aware of ourselves and who we are and how we interact, we become more capable of being aware of our patients, being aware of our teammates, and being able, in my case, to sit down and shut up once in a while. And it's that awareness that I believe is the foundation of interprofessional education. And I don't think it's as squishy as the CFO sometimes wants to make it out to be. I actually think it's extremely strategic. And it's worth investing in. And it needs to be more than just an occasional feel-good session where we do kumbaya and then go home and all do the same thing the next day. Those don't work. The 2-day retreat with nothing following it that actually embeds it in the operations does not work. It's a waste of money. So please think about how to operationalize interprofessional education, which means addressing hierarchy. It means addressing, do people feel safe working here and actually speaking up? It means not trashing each other behind each other's backs, and when it's happening, calling it out as something that's holding us back, not moving us forward, and being safe to do. And it means stopping something that's going to harm a patient at the risk of you even being wrong. Because you might be. And it's okay. The fact that clarity is needed was enough once a team understood it was about something bigger than you challenging me, something we agreed to accomplish together and we're sharing accountability for, gave people permission to use the phrases, and ultimately resulted in the change of the culture of our emergency department. Thank you.
Okay, I don't believe that we have our fearless leader here, so I will be thanking Dave for yours. Oh, yay, here he is. Yay.
To the rescue.
Yes, absolutely,
That was
please.
terrific.
I'll let you go ahead.
You know, that was only caught the last half of it, so I apologize. But you know, the culture piece of that is so important, and it's certainly true in the clinical environment, but certainly true in the administrative environment and the education environment. I mean, everything that you just said about the clinical environment, you could translate into any other unit on this campus. In terms of being able to communicate, creating an environment of respect and communication, breaking down hierarchy, and creating a safe place. And so I think those are very, very telling words. I think we can take those to heart. I think soft skills can be taught. We actually have done a study. We've shown that when I was in ENT. We measured empathy in our faculty, our alumni, and our residents. And we did not do that in an interprofessional way. We probably should have. And we didn't do so well. But after a couple of years of programming, you can show. Actually, nobody ever showed that you could change those measures. Everybody thought you were sort of born empathetic, and you either are or you aren't. And that's actually not true. You can teach these skills, and you can get better at it, but it does have to become part of the culture. It has to become part of the nomenclature. And it became a joke. It became a running joke of, boy, Dave, that was not a very empathetic thing to do. But it worked, and we could measure patient satisfaction with that. Yeah. And it changed 20% as a result of that. And so you can change your environment, but it does take leadership, and the leaders are in this room to do this in the interprofessional education environment in particular. And it does have to start at the top to really start to create that change. A lot of these skills also actually are part of the Jayhawk Way. If you've not had an opportunity to participate in that program, these are skills that are taught. And how do you communicate more effectively? How do you have some of those hard conversations? How do you challenge people in a more respectful way, but in an effective way, so that you can speak up? You can be that brave person to speak up in the room and break the silence. I mean, that really does take a lot of courage to do that. And it's very important. And then I think the Team Steps effort is another great effort at that. And the problem with that is, to your point, that's an all-in effort. We got 800 people together, but we need to operationalize it. And so that's fine, but we need to go out and show our students that we actually practice what we preach. And that's where the challenge, I think, happens right now. And when we talk to students, often what we hear is, well, you tell us that we are supposed to do all these things, and we go out and we see none of it being done. And so, and that starts with us. So you know, we're teaching those coming up behind us, but frankly, we have a lot of professional development to do, I think, for the current faculty and staff as well. So it is a generational shift. It's an important shift. The data has shown safety follows that, and that's critically important. Economics follow that. And I think you've demonstrated that as well, and certainly, you know, in our hospital environment, you know, back in 1998, a focus on patient satisfaction, which encompasses many of these things, not all of them, but many of these things, you know, does translate to economic benefit if you can perform at a high level. But once you sort of hit that mark, there are these other issues, and if you're going to really take it to the next level, you really have to start changing your culture. So that was outstanding. That's not why I'm here. That's why you all are here. No, and hopefully this has been a really good day for you, and thank you, Christy and team, for organizing this. And we've added a different element to this, which is really a discussion, and I think appropriately with this group, of the Chancellor's Distinguished Teaching Awards. Those have been given for a long time, but actually these awards are given in Lawrence, and they are given at the Teaching Summit that occurs in August every year. And if you've not had an opportunity to participate in one of those, I'd strongly recommend that you do. Carve some time out and go do that, because they're very good, and several of our teams run those sessions. And they're quite good, but they're for educators of all types. But that's where these awards are given. And we have not historically recognized that on this campus, even though every year we have multiple recipients of that award. And so, you know, it was a great idea, I think, to use this venue to start to recognize those Chancellor's Distinguished Teaching recipients of those awards. I've been in this job now since 2013, almost 4 years. Hard to believe. It's gone very fast. But we're going to roll it back to 2013 to recognize those folks who have received those awards over the years. So if you're here and I call your name, please stand, and we're going to recognize them year by year. So in 2013, we had Kathleen Davis in pediatrics, Diane Ebert in nursing, who I don't think is well, you don't have to stand, Kathleen. And Ed Ellerbeck, who I think I did see here. Yeah, congratulations, guys. And this award is presented by the Chancellor, but it's really determined, the recipients are determined by a committee of our peers, our faculty, and our students to recognize those who are the outstanding teachers amongst us. And in 2014, that was Joe Fontes in biochemistry. Joe's here, yep. Ken McCarson, pharmacology. Emily Peterson in family medicine and nursing. The 2015 class was Lisa Gilmer, pediatrics. Lisa's here, I saw her, yep. And Mary Meyer in nursing, is Mary here? There she is. Boyd Smith, pathology. Salina. And Wolf Zuckert in microbiology. Is Wolf here? There he is. And I know you're hanging in suspense for the 2016 class, which was Sandy Billinger in physical therapy. We're calling this the year of Sandy, by the way. Elaine Domain in nursing. Erica Howe in internal medicine. Is Erica here? Oh, she made it, yeah. And Gary Doolittle in medical oncology. So we just thought this was a great opportunity to recognize the best and the brightest of the teachers among us, and recognition that the Chancellor has bestowed upon them, and we certainly are very, very proud of them, and look forward to many of you joining those ranks in the years to come. Thank you again, Dr. Mohn, for being here and your message. I think it's very powerful and very timely. All these things are an issue once in a while in Kansas. We're a much more respectful state than Minnesota, but it's not true. But we call it Kansas nice. We pretend that it's true. No, but these issues are very, very profound and very timely. So thank you very much. And let's all go have a reception.